pathways up here. Some of this you will need to know for the physiology later, and maybe, as I say, in some of these cases, the anatomy as well. But that's not our purpose now. We're just making some general observations about the organization and relationship of the autonomic fibers to cranial nerves, and then we'll build on that once we have mastered this very simple understanding. But I do want to point out a few things about these tables. First of all, you don't have to memorize the table. What I want you to pay attention to in the tables, number one, know the names of the ganglia. So you can see them listed up here. And so you have a table for each one of those ganglia. And then in all but one case, you have listed parasympathetic, sympathetic, and general sensory. All right, so that should surprise you right off the bat. Because what do we know about autonomic innervation in the head? What are the ganglia? They're all parasympathetic. But we saw an illustration earlier of where, for example, the sympathetic fibers just intrude into the parasympathetic ganglion. They don't synapse there, but it's often the case that the parasympathetic fiber will go right through it. So that's anatomically just one complication or one annoyance we have to deal with. Now, with respect, for example, to the ciliary ganglion, you can anticipate that it's primarily associated with vision, primarily associated with the intrinsic muscles of the eye. You can look at the reflex pathway up here. Parasympathetic innervation or parasympathetic fibers that synapse in the ciliary ganglion are primarily linked to that visual, light response, that pupillary light reflex. Now, sympathetic, and you'll notice the terms here, sphincter and dilator. What does a sphincter suggest to you? Anybody else called that when they were in junior high school? Sphincter, right? Contraction. Dilation implies getting larger. So that tells you sympathetic surprise. People getting now. Again, I don't want to get into a long discussion now of the contribution of this to that process. If we have time, we'll talk more about this later. Just think in terms of general function. Sympathetic dilator muscle enlarging the pupil, but the primary reflex is mediated by the parasympathetic innervation. And then it has a third category here called general sensory. You see the V1 there. So it says sensory to the cornea, iris, ciliary body. Here we're talking about somatic sensation you can of which you are palpably conscious. So that's what, in the textbooks, when we talk about these fibers and we classify the fibers, you'll see reference to general, general, special, afferent, efferent, and then there will be references to visceral or somatic. I don't even want to touch that terminology, that classification, because it's based on embryology. But I do want you to have a general understanding of what those terms mean. So again, this would be somatic sensation. Now, these other tables tend to follow the same pattern, except look at pterygopalatine here, otic, submandibular. These all refer primarily to what cephalic processes, what are these ganglia regulating in your head? Exactly right. Salivation. Salivation was the answer. And so that kind of simplifies that. But let's build on that just a little bit. And we don't have to get into this in great detail. We don't have to know all the words here. But let's look at the pterygopalatine. Parasympathetic secretomotor. All right, I mentioned several glands here. It's talking, for example, the lacrimal gland. We'll talk about tearing later. The glands of the mucosa. But that's parasympathetic secretomotor. It's simply innervating secretion from those glands or triggering secretion. What is the sympathetic? Now here's another general pattern. Smooth muscle control of head and neck vessels. Can somebody say that in a simpler way? What's the sympathetic innervation doing in this region, in the region of the pterygopalatine ganglion? Vasomotor, exactly right. And remember, the blood vessel. The only complication here is all this saliva. Where do you get your spit? Where does it come from? All right. So where do those glands get it? That's where you hold it. How do they make it? Where does it come from? fluids in your body come from? Huh?
Goblet cells?
Well, goblet cells often secrete mucus, but even in that case, where does it come from? What? I guess what I'm asking is, where does CSF, we've used that example, where does CSF, the blood, yeah, all of this stuff comes from the blood. All right, so when you look at the vasomotor function here, just remember they're often related. The blood flow into a secretory or glandular tissue is going to be related to the secremotor function. But here's the rule. Most of the time, sympathetic regulates blood flow. That should be always your first guess, unless you have reason to believe otherwise. And then all we're saying is that if the tissue is a secretory tissue, it is very likely to assume that blood flow and secretion are related, directly related. And then once again, through the palatal, we have the somatic, sensory to the mucosa, the nasopharynx, and the nasal cavity. So this is just a somatic sensory component that is present. So all of these ganglia, these parasympathetic ganglia actually have multiple functions. They have sympathetic fibers, they have parasympathetic innervation, but they also carry or contain along with them sensory function. But really, what is that sensory function coming from? A cranial nerve. It's usually the sensory component of a cranial nerve. Let's drop down to the bottom one here. Well, let's actually look at the odic because it's so simple. Odic is secretomotor of the parotid. Odic, parotid, para just means beside the odic ganglia. I'm sorry, beside the odic ganglia. And then the sympathetic is to vessels within the parotid gland. That's straightforward. Sympathetics regulating the blood flow into the gland that is going to filter the saliva from the blood. And then the submandibular, we'll look at these later. Once again, parasympathetic secretomotor to the salivary glands, the submandibular salivary glands. What's the sympathetic doing? Same thing again, regulating blood flow to that gland. And we don't have to worry about general sensory here. Whenever I see question marks, I just write it off. Don't worry about it. All right, any questions then about the general pattern? I just want you to see this pattern because this is going to crop up again when we talk about autonomic. And this is just a discussion. You should know this thoroughly. We've talked about Horner syndrome. You should be able to tell me why it is then that sympathetic innervation to the eye involves pathways in the neck, shoulder, all the way down to T1. Okay. We looked at that pathway before, and we'll go over it again physiology class next week. For the test, make sure you review that part of it. Any questions about the Horner?
What's Horner?
Oh, Horner's again is if they're all right. So let's say you want to express surprise as a part. Well, again, I think the better example of Horner's is tonic regulation of pupil size. And so, as long as the sympathetic nervous system is hooked up to your pupil, then your pupil is going to be a little larger than it otherwise would be. And about 20%, most of your ability to elevate your eyelid is that superior palpebral muscle we just talked about a moment ago. But about 20% is also sympathetic. So in Horner syndrome, if this pathway is severed or impaired in any way, the two classic symptoms are change in the size of the pupil, the sympathetic dilation is reduced, so the pupil is usually smaller. And you get a little ptosis. What's ptosis? Yeah, you can have it.
What is it? I'm sorry, what was the ptosis?
Ptosis is when the eyelid droops a little bit. There are many, you will have in your clinical panoply many causes of ptosis. This is only one of them. It's just a drooping eyelid. Usually it's mechanical. Any other questions about that? All right, good. So let me just repeat that. That concludes the material for the first test. We want to turn our attention now to a brief discussion of the face and the scalp. Fortunately, a lot of this we've already mentioned. A lot of textbooks, you'll find many pictures, many images out there with this mnemonic describing the layers of the scalp. And you can see, again,
Where'd you get that?
from exterior to interior, the skin, the integument, there is a sort of dense connective tissue under that. Then, this thing you're looking at here, the cranial aponeurosis, we'll go over again in just a moment. Then some looser connective tissue, and this is where if there is some type of trauma, the scalp usually detaches from the underlying structures. And then the pericranium, that's just really referring to an interface tissue, sort of periosteal and connective tissue that binds the overlying tissue to the skull. Now, we've talked about this aponeurosis. Remember, the term aponeurosis is generally a broad flat tendon. And in this case, the broad flat tendon overlies the skull, in association with the tissues up here, between what is sometimes called a digastric muscle. I don't know that I like that terminology, but digastric means a single muscle that has two bellies. Right? So if you go along with that description, then here is the occipitalis, or the occipital belly, and this is the frontal or frontalis belly of the occipitofrontalis, and then that aponeurosis is suspended between the two. Of course, this should afford you the ability to shift your scalp anteroposteriorly. I can't do that, but that should afford you that ability. Also, the frontalis contributes to the furrowing or the decreasing of the forehead, if you can do that. The muscles here, as you can see, are all branches of cranial nerve 7. These two bellies are powered by cranial nerve 7. So I talked a little bit about the scalp. As I've indicated, there's the skin followed by this denser connective tissue, which is usually fairly profusely vascularized. If there is profuse bleeding from the scalp, it's generally originating in that region. And then if there is delamination of the tissue, where the scalp separates from the underlying tissue, it normally occurs at the level of the loose connective tissue, and that too can be attended by significant bleeding. So we talked about the motor innervation to the occipitofrontalis. The scalp itself is supplied by branches of cranial nerve 5 and the cervical plexus. The cervical plexus refers to the first 4 cervical nerves, 1, 2, 3, and 4. So you get sensory innervation from both of those sources. And all of these branches here, I'm not so interested in you memorizing these branches, but I would expect that you'd be able to deduce the approximate region based upon the name. Supra, for example, means what? Above. Now, we mentioned trochlea a moment ago. Where did we talk about a trochlea? Yeah, the superior oblique. Can you remember that? So you should, if you see supratrochlear, something approximately superior to the trochlea, yeah, that supratrochlear is just about in here somewhere. This is where the nerve emerges. Supraorbital would mean what? Above the orbit. So you get the idea. Auriculotemporal in the temporal region near the ear back here. And then again, all of these are either in one of these illustrations if you want to locate them. Be aware of the distinction between branches of the cranial nerve and the cervical plexus. Here we're looking at a synopsis of blood supply to the scalp. Remember, the blood to the head is going to originate in these common carotid arteries. Common carotid then separates into the internal and external branches. And in this very simplified description that we used earlier, the internal carotid supplies the interior of the cranium, the external, the exterior, with the exception, I guess, of the middle, the meningeal arteries, but we won't worry about that now. The general rule is this, and we'll go over some of these arteries later. But for now, understand that the scalp is entirely innervated by branches of the external carotid, with the exception of the upper forehead. And you can see the branches up here supraorbital and supratrochlear that are actually branches of the internal carotid. And again, they supply this region here. Moreover, what do you call a vast branching network like this? Yeah, so you should know that in reality there's extensive anastomoses between the internal and the external, especially in the anterior scalp.
Can I ask that again as a question? It's
No.
not.
Yes.
So
I did. You give me a choice.
So the top of the external structures are supplied with blood by the external carotid,
Yeah, all of
with the exception of the top of the forehead.
yeah, right here. And then when these emerge right here, they still get all mixed up with the supply from the external carotid. And as I say, we'll go through these specific arteries in more detail later. But here, when it talks about the superficial blood supply, it's just pointing out that all of these arteries that you see here, here's the facial artery, maxillary here, transverse facial, and so on, the auricular, superficial temporal. All of these are branches of the external carotid. Now, with respect to drainage, this gets a little more complicated because the system down here has an entirely different name. So let me try to explain what I'm talking about. It will be the case for most of our discussion, our anatomical discussion, that the veins run alongside, the large veins run alongside the arteries, and they share the same name. And for much of the exterior cranium, that will be true, although they don't always follow the same path. But things deviate dramatically as the veins, as the drainage of the scalp, the drainage of the external of the cranium, externally, not internally, but externally drains back into the jugulars. And so we'll have a special terminology for that. So it's not really too much about that. But otherwise, you have the facial vein here, maxillary vein, and so on, just as you do the arteries up there. It's just right in here where the terminology changes, and we'll go over that a little later.
Now we'll move on to look at the scalp. To understand the scalp, we'll start with a dissection in which all its layers have been removed, exposing the scalp. The dome of the skull, known as the calvaria, is formed by bones that we've seen in the previous tape. The frontal, parietal, and occipital bones, and on the side by the squamous part of the temporal bone. The temporal bone is covered by the investing deep fascia of the temporalis muscle. Overlying the calvarium is a layer of loose connective tissue, the areolar layer. It overlies the deep temporal fascia too. The areolar layer separates the bone from the next layer that we'll add, the assembly of structures known collectively as the epicranium. The epicranium is formed partly by tendon, partly by muscle. To see it better, we'll add all of it to the picture. Over the dome of the skull, the epicranium is formed by a sheet of tendon that's known as the gallia, or gallia aponeurotica. Two muscles are attached to the gallia. In front, the frontalis, and behind, the occipitalis. The occipitalis muscle arises from here on the occipital bone, above the superior nuchal line. It inserts into the gallia. The frontalis muscle arises from the gallia and inserts into the skin of the lower part of the forehead, close to the eyebrow. These two muscles produce important movements of facial expression. When occipitalis and frontalis act together, the eyebrows rise. When frontalis acts by itself, the forehead is pulled downward in a frown. The pull effect of a frown comes from the added effect of these not very separate muscles, depressor supercilii and procerus. and by the more deeply placed corrugator supercilii, which pulls the eyebrow medially, causing these vertical wrinkles. On the side of the head, the epicranium is formed by this area of dense connective tissue, the superficial temporal fascia. In some individuals, as in this different specimen, the epicranium includes the vestigial auricularis muscles, which can move the external ear. Now we'll add the more superficial part of the scalp to the picture. Firmly attached to the epicranium is a layer of fibrous tissue interlaced with fat. Above this is the hair-bearing skin of the scalp. These are the hair follicles, which extend through the thickness of the skin.
All right, so we'll look at some of these facial muscles in just a moment. Anybody familiar, have you run across in your clinical experience a platelet-rich plasma? Sort of a cure-all soup for everything.
Yeah.
It's a sort of a thickened, super thick homogenate of the blood. But apparently it's good for hair growth too. I'll find out, doggone it. But you know, it's used for everything from arthritis to a variety of other conditions. Yes.
A guy that I know that I trained with was in the NFL, so they used to juice him up with that. Basically, if he turned over his ankle or had a high ankle sprain, so it's something that would take 4 to 6 weeks. Literally, they take out blood, spit it down, take the plasma, put it back in a bunch of different places around the injury, and in like a week or a week and a half, you could be done with a high ankle sprain.
Yeah, some of the literature is very impressive. Again, it's used for joint osteoarthritis, certain other types of inflammatory joint disease. I would think that would be a perfect application because you're dealing with an otherwise healthy joint in a fairly young person. Some of the studies, though, show that what I've looked at, especially with respect to arthritis, is the benefits are very short-lived. And again, that wouldn't be a problem if you're an athlete. That's why we all shoot up with the steroids too, right? Don't we all do that? So here's a little graphic again of some of these facial muscles. And we understand that again that these are all going to be innervated by cranial nerve 7. And you can see over here in bold the branches of cranial nerve 7, temporal, zygomatic, buccal, mandibular, and cervical. Once again, I'm not so concerned that you memorize these as that you be able to localize them by their names. Buccal is just referring to the oral cavity. And so if you were shown a picture like this and given some choices, I would imagine that you could deduce where these are based upon the relative location: temporal, zygomatic, buccal, oral, mandibular, and then cervical down to the neck. The muscles of the head are classified in a variety of ways. We talked about the extrinsic muscles of the eye, extraocular muscles. We talked about the intrinsic muscles of the eye. There's some odd little middle ear muscles that help, as we've indicated, to dampen and regulate the movement of the bones inside the middle ear. We're mainly going to be focusing on the facial muscles, and to a lesser extent the muscles of mastication. There are some soft palate muscles that we'll probably talk about next week. And then we'll also talk about the intrinsic and extrinsic muscles of the tongue. Now, there are several slides here that list the various classes of facial muscle. For example, it'll say orbital group and nasal group. I'm not at all concerned about your ability to put these in a group. What I want you to be able to do, once again, is just identify in an image the orbicularis oculi, the corrugator supercilii, nasalis, procerus, and so on. You have multiple images that we'll look at in just a moment. There's the oral group, orbicularis, oris, buccinator, lower group. And the images here at the bottom, this is actually an art, what's the word I'm looking for, an art exhibit from the 1970s in which the subject here received these electrodes had been placed on his skin while some mad person off to the side would excite them in a presumably artistic fashion. And you can see, over which he has no control, the movements of the facial muscles resulting from those electrical excitations. Something to do this weekend if you
Yeah, definitely.
run out of amusement. Facial muscles also include muscles such as the risorius. The risibility is your propensity to laugh. So the risorius muscle is important in your ability to express laughter. The zygomaticus muscles, again, retraction of the corners of the mouth. And then you have several levators and depressors that help to either elevate the lips or lower the lips. The platysma is a broad sheet of muscle that's very, very thin. In fact, it's almost considered fascia more so than muscle that covers the entire neck. In fact, this is the platysma here. Can any of you get your platysma to do this?
Uh-huh.
You have two, well, yeah, I can do that.
Are the side ones the same?
Yeah, that's all. But I've never seen this banding before. You can do that? Yeah. Yeah, you can sometimes get it. There's, you see male aggression sometimes demonstrated through contraction of the platysma, but it's a kind of puny muscle. If you're going to show up your muscles, the platysma is not the one. But this is I would run at this. And of course, this is often the target of Botox and that sort of treatment to sort of alleviate this. We've talked about the occipitofrontalis. Ackland took us through that. So over here on the left is a list of facial muscles that you should be able to recognize. And as I said, you have several slides here that take you through most of these. We can see the frontalis here. There are two orbicularis muscles. There's a orbicularis oculi, which are a couple different layers of this that will differentiate, that sort of circumscribe each eye. There's an orbicularis oris that sort of articulate the lips circumferentially. Here the zygomaticus, the major is lateral to the minor. Nasalis, sort of retract the nares there. We talked about the levators elevating the lips and the depressors pulling down on the lips. That's the general function. There's a mentalis as well down here. And we'll look at a picture of the risorius in just a moment. The buccinator is deep in there. The buccinator is a very thin sort of muscle in the wall of the cheek that helps you keep your cheek against your food when you're chewing. And then there's that platysma, much more graceful than in the prior image. Here are the four muscles of mastication. We'll talk about these in more detail later, but you already know how they're innervated. What innervates the muscles of mastication? Exactly right, V3. You're exactly right. The mandibular branch of cranial nerve 5. So again, the frontalis, the orbicularis oculi, orbicularis oris. Here's the procerus muscle that you saw in the Ackland. Here's the corrugator supercilii that enables you to create that furrow there between your eyes. The nasalis. We can see the two zygomaticus here. Here's the levator labii, medial to the two zygomaticus muscles, again, major and minor. Here's that risorius. Haha, that's what the risorius is all about, laughter. It was inappropriate. If you ever read that, I remember reading about the itinerant ministers, the American ministers that used to travel the countryside of the 18th century, and they would always talk about the dangers of elevated risibilities. And so I've always taken that to heart in class for trying to avoid that. But here's the risorius muscle that's very critical for your ability to form a smile. And then the depressors, there's several depressors, all of these, again, pulling the corners of the mouth downward. This is the mentalis in here, and then the platysma inferior to all of them. Is anybody impressed with the Botox? Now, what is the Botox? What does the botulinum toxin do upon injection?
Paralyzes the
Yeah,
muscle.
that's sort of a temporary paralytic. You can see some of the target areas here. They call this the danger zone. What would be the danger in introducing? Well, they're really targeting the ability of the nerve to contract the muscle. They're not too concerned concerned up here, why would this be problematic for a cosmetic, I guess it was cosmetic surgeons or cosmetic? There was a, should say this, there was a NOVA graduate about 10 years ago in West Palm Beach who actually killed a couple of people with too much alcohol.
A PA grad or a PO grad?
No, it wasn't a PA, no, I'll just say that. No, the PAs clear them out by the dozens. No, I shouldn't have said no, but I'll be in trouble. I'll probably be fired. It'll probably be somebody else I'm going to Although you know the starting, I've never heard that, most places would call a medical school, but here it's going to be called an allopathic school in Miami. This is the danger zone because if the muscles in that area were paralyzed, what would you lose the ability to do?
Chew.
Well, no,
Raise
you still have muscle.
Oh,
Yeah, you no longer smile and that there. And so it's generally the case that they don't want you unable to smile. That would not improve your social. The whole purpose in going into this place is to look more like the one on the bottom, right? If you can't smile, that would defeat the whole purpose. What is the relationship between these two individuals?
None. The
They
shirt.
got the same, which might tell you what. It's the same person. He went into he was on an airplane, he went into the bathroom, he came out, made the bathroom looking like that on the left, and came out looking like that on the right.
Sure.
I think it was try to avoid customs or something, immigration. So it's quite a work of art. That guy can use some Botox. What we're looking at here is
For real, what was it? Professor,
embryological-
what was that?
I'm sorry?
For real, what was that picture about?
Yeah. He had fashioned a mask that enabled him to, I think it was a concern over immigration or something. He wanted to go to another country or something and claim for refugee protection. But yeah, he just had a nice look. And look at the platysma down there, just beautifully crafted. Yeah. I mean, I wish mine were a mask. I could just walk into an airplane bathroom and come out looking like the gun. What we're looking at here is a little animation of the embryological formation of the cranium, the visceral cranium, the face. See if you can locate, as it develops, see if you can locate where the eyes and the ears are. So we're looking at a very early fetus here. And there is the eyes and the ears.
That's a human.
Yeah. You can see the pharyngeal edges down there, pharyngeal fissures. Yeah, it all worked out in the end. Ackland's talking about the muscles of mastication. Remember, there are four of them. There are the two pterygoid twins, medial and lateral, the temporalis, and the masseter. And let's screw over this one a little bit too, because I don't know. Remember, the pterygoids get their name from their attachment to the pterygoid wings of the sphenoid.
Process and the zygomatic arch. This lets us see the infratemporal fossa and, behind it, the lateral pterygoid plate.
These are articulating the mandible.
Here's the lateral pterygoid muscle. It's quite small, The lateral pterygoid muscle arises partly from the underside of the greater wing of the sphenoid and partly from the lateral aspect of the lateral pterygoid plate. The fibers of the lateral pterygoid muscle run backward and a little laterally. We'll go round to a medial view to see where they go. The main insertion of the lateral pterygoid is into this hollow on the front of the condylar process. The lateral pterygoid also inserts onto the capsule of the temporomandibular joint and into the front edge of the articular disc. These windows in the capsule were made artificially, as in the shot that we saw previously. Now that we've seen the lateral pterygoid, we'll add the medial pterygoid muscle to the picture. The medial pterygoid muscle is larger than the lateral pterygoid and runs in a quite different direction. The medial pterygoid muscle arises from both the pterygoid plates, the medial aspect of the lateral one and the lateral aspect of the medial one, also from this corner of the maxilla, the tuber. The fibers of the medial pterygoid muscle run downwards, backwards, and laterally. They insert here along the inner aspect of the angle of the mandible. Before adding the next muscle, the temporalis, to the picture, we'll put the coronoid process back in place, since that's where the temporalis inserts.
For the condyle.
Here's temporalis, the largest of the muscles of mastication. It's shaped like a fan. The temporalis arises from the wide area on the side of the skull that lies within the temporal line. The fibers of temporalis converge from above and from behind on the coronoid process. They insert on the outer aspect and the inner aspect of the coronoid process, and also here on the anterior part of the ramus of the mandible. Now we put the zygomatic arch back into the picture. The temporalis muscle lies inside the zygomatic arch. Near its insertion, the temporalis is a thick muscle. It occupies the whole of the infratemporal fossa. The temporalis muscle is covered over by this dense layer of deep temporal fascia. The fascia is attached to bone along the zygomatic arch and all the way around the temporal line. Lastly, we'll add the masseter muscle to the picture. Here's the masseter. It's a thick, powerful muscle. The masseter arises from the anterior 2/3 of the lower border of the zygomatic arch on its outer aspect, and from the whole length of the arch on its inner aspect. The fibers of the masseter muscle that arise on the outside run downwards and backwards. Those on the inside run straight downwards. The masseter inserts into this wide area on the angle and ramus of the mandible. The masseter muscle on the outside and the medial pterygoid muscle on the inside converge on the angle of the mandible in very similar ways.
And of course, what they're doing is articulating the excursion of the mandible. There are several slides here talking again about cranial nerve 5 and 7. As I indicated in our discussion of cranial nerves, we're going to be very repetitive in our discussion. So this slide and the next few are simply representations of some of the branches of each of these. And we're looking at 7 here, the function of 7 with respect to the muscles of facial expression. And you also know how cranial nerve 7 both enters the cranium from within and passes through the stylomastoid foramen. So we're going to look at these in a little more detail. The facial nerve, as we've indicated, and again for the second anatomy test, we should know the functions a little more precisely. than the overview indicated. Muscles of facial expression, the posterior belly of the digastric. We're going to find later that the digastric is one of the hyoid muscles, one of the strap muscles of the chin, along with the stylohyoid. And the stapedius. Stapedius, again, regulating the excursion of the middle ear ossicles. In addition, the facial nerve affords taste sensation from the anterior tongue and somatic sensation from the region of the throat. So we're looking over here at its emergence from the stylomastoid foramen and then its branching. The trigeminal nerve, remember, has three branches. You should know the three branches, the ophthalmic, maxillary, and mandibular. We're looking at the V1 here, the ophthalmic branch, emerging from the superior orbital fissure. And again, the branches, supraorbital, supracochlear, we looked at these before. What I really want you to be able to identify here is the region of innervation. I don't think we have, I don't know that there's an anatomical term to describe the area of skin that is innervated by a cranial nerve branch. For example, what is a dermatome? Does anybody recall the definition of dermatome? What the area of the skin innervated by one? Not exactly, not quite, because the spinal nerve is a mixed nerve. Dorsal root, yes. So this is not that. This would not be equivalent to a dermatome in that it's not a receptive field, so I don't know if we have a term to describe this. But in any case, be familiar with the general area of innervation of the hair. This is the area of innervation of the maxillary nerve, that it exits via the foramen rotundum. We looked at those foramina in the base of the skull earlier. Once again, I'm not so absolutely concerned that you'd be able to identify the branches of V2. These are all sensory, but I do want you to be able to recognize the prefix and the suffix, such that you could probably reason your way to identification of these branches. Infraorbital, below the orbit of the eye, zygomatical temporal, sort of extending up from the zygomaticus into the temporal region. It's not shown here, by the way. And then the mandibular branch is important for a variety of reasons, but primarily because it includes the innervation to those muscles of mastication we just looked at. So there you can see the auriculotemporal branch, the buccal, and then the mental branch. I don't know if you're aware of this. Apparently, if you have, I guess now, if you have all your photos in Google Photos, it'll basically identify you or a loved one. There's something called the Wombat test. If you happen to have a picture of a wombat, it has the ability to identify a wombat. In any case, it will show you for your entire life as many pictures as you want to feed to it and put them in succession. But what has been found is that the more you smile early in life, the more likely you are to remain there, if that is an objective. But smiling seems to be an excellent predictor of marriage. I want to talk a little. We talked about the vessels of the extracarotid and the relationship of the branches of the external carotid to profusion of blood supply to the scalp. We indicated the anterior scalp is supplied by the branches of the internal carotid. But at this point, I also want you to begin recognizing some of these major blood vessels that emanate directly from the external carotid. Most inferior, or at least anatomically, would be the facial artery that you see here. You can sort of see it curves around the mandible there. First inside the mandible, then emerges about midway to the exterior. Then supplies both the mandibular and maxillary alveolus. And the end artery is usually taken to be the angular artery. The end artery of the facial is usually taken to be the angular artery, which is up there on the side of the nostril, medial to the eye. can see the maxillary, you don't see it very well here, that's the maxillary artery there. And the maxillary artery is another large branch. We'll look at a better image of that. Now, transverse facial, sometimes used in transplant procedures. This sometimes is harvested if they're doing facial reconstruction surgery. They'll harvest both the nerves in this region and the artery for facial reconstruction. And then the superficial temporal is just a continuation of the external carotid. You can see in the AP revealed cadaver, the facial artery here, the maxillary, and then superior to this, not quite evident in the cadaver, but this is the transverse facial artery. The maxillary artery, surprisingly, if you go back to this, and I'm going the wrong way here, this little branch down here called the mental artery, you might assume that that is a branch of the facial artery. It is not. This mental artery is a branch of the maxillary up here. And so it's listed there, mental artery is a branch of the maxillary. Okay, that's what I'm pointing out here. So here's the facial artery again. You can see the maxillary here, and here's that branch that gives rise to the mental ghosted there. And then the maxillary also extends branches into the infraorbital region, even a portion of the maxillary alveolus. Now, as I say, we're going to talk more about the venous drainage in a moment, but I think it should be evident even in an image like this that the venous drainage at the base of the skull does not correspond to the organization of the arteries from that region. You do have, for example, a facial vein, just as we have a facial artery, although they don't necessarily follow exactly the same path. So that would be the facial. You also have a maxillary vein here. This is your superficial temporal. And all of these eventually will empty into the external jugular. So for the most part, all of the veins of the scalp and of the visceral cranium and so on, externally will eventually end up in the external jugular. It's just that this region has a rather peculiar organization. And I think because it's Friday and I'm out of energy, we'll pick up there then on Monday. So I'll be in the office today if you have any questions, at least for a few hours, and by email as well.